jugular foramen from the endonasal perspective. So it's very nice
No,
dissect.
no, no. Thank you.
So let's see if Kentaro is connected. Kentaro, are you there? Yes,
Okay.
great. Hi, Kentaro. So Kentaro
Hi.
Watanabe, another friend. Very happy to have him here. So let's start, Kentaro, please.
Hi, Paolo. That's good. Thank you. Thank you for introducing me. So it's almost at 2 o'clock in Japan, and so yeah, I'm sleepy, but I try to do my best. Okay. Oh, just a moment. So as so Paolo is he already presented about the jugular foramen anatomy, and also the JP also the explained about the middle side, so medial side of the jugular foramen. Maybe as I will talk about just add the information that's around the jugular foramen. So in my career and I spent 3 years in Fukushima fellowship, and then after that 3 years in the Sebastian fellowship. So as I did a lot of dissections in the cadaver lab. So it's, even though I spend a lot of time in cadaver lab, it's a jugular foramen is the most difficult place and complicated place. This anatomy is very complicated. So Albert Lawton, he also mentioned that this area is the most complicated. So there's the nerves and the veins, and all the structures covered cover the jugular foramen. So we cannot see this inside of the jugular foramen in the clinical case, but you can see just we can see these areas only cadaver head. So maybe we already know that you can skip here, so we can see that the veins along the jugular foramen is also very important. Inferior pectoral sinus, pectoral sinus, jugular foramen, sigmoid sinus, and the jugular valve and the internal jugular vein. And then just between the petrous bone and the occipital bone, there's a jugular foramen. So and also here, this 9, 10, 11 is located around here. And so when you see the inside of an interjugular lesions, you can see the 9, 10, 11 like that. But you cannot see the inside of the jugular foramen. So when you see the inside of the jugular foramen, so there is some complicated anatomy. So here is the 9th nerve has a superior ganglion and the petrous ganglion. And the 10th nerve has a jugular ganglion and the ganglionosis. And then these nerves is anastomosis with each other. But actually, I cannot find these nerves. So maybe there's no this connection between the 9 and 10. Just a 9, 10 is connected with the other nerves like that. But it's okay. So it's here. There's a inferior pectoral sinus located between the 9 and 10. So like that. So I can show that the anatomy. So after that, so these areas is very complicated. So here, so you can see 9, 10, 11, and then inferior pectoral sinus located between the 9 and the 10, so like this. And then here is the 12 nerves. Hypoglossal nerve is like the S shape. S shape is the nerves like this. And then here, this is jugular ganglion, and then ganglion nodes is like here. And actually, the ninth nerve has it shows that the ninth nerve has a 2 ganglions like this, but in the anatomy. So this I cannot see the small the ganglions like here, but there's a small nerves from here. This is a jugular in the Jacobson nerve. So it means that maybe here there is a small ganglion, and here around here there's a small ganglions also, but it's already difficult to find it as a ganglions from on the nice nerve. So and also these nerves was anastomosis with there are a lot of connections. 9, 10, 10 to 11, 11 to the 10 to 12, and and 9 to the facial nerve, also the 10 to 9 to the facial nerve, also like that. So it'll be complicated. So I can show that cadaver dissection. So this is retrosigmoid craniotomy. Here, this is a sigmoid sinus. At first, we can remove the retrosig, the bone is from the retrosig, and then open the foramen magnum. And then you can see that the posterior condyle emissary vein is posterior condyle emissary vein connected to the subcondyle plexus, and then it's going to the jugular valve. So then after that, as we can see that the anterior condyle emissary veins, anterior condyle emissary vein is the same canal as the hypoglossal canal. So after exposing these veins, after that, we moved on to exposing the jugular valve. So here, this is above the jugular valve. So when you remove these bones, you can see the cochlear aqueduct just below of the medial side of the jugular valve. And then we can retract the jugular valve that push down, so you can see the nice nerve canal. So here, this is the nice nerve canal. And then when you see, if you can see the jugular foramen from the below the jugular valve, so you can see the 10 and 11 around here. So after exposing the jugular valve and internal jugular vein, and then I can remove the wall of the jugular vein. You can see there's a medial wall of the jugular sigmoid sinus and the jugular valve and the jugular vein. Then after that, you can open the dura here, so you can see the internal interjugular lesions of the jugular foramen here, 9, 10, 11, and the foraminal segment of the jugular foramen. Here's a nice nerve is coming from. Here's a nice nerve canal is going to the anterior. And then here's a small branches. This is the Jacobson nerve coming from the jugular foramen. Here, this is ganglions here. And 9, 10 nerves, and also here, as you can see, that if you put the sinus located, the round is between the 9, 10. And then they can cut the inferior pituitary sinus. And then now, so you can see all the weight of the 9, 10, 11, and the interdural lesions, foraminal segment, and the extradural segment, extracranial segment. And here, 11th nerve, 10th nerve, and this is a connection. There's a between the 10 to 12 here. And then here's the inferior ganglion of the 10th, so like this. So it's all the nerves is anastomosis around these cervical regions like that. So, and also here, this is the foraminal segment. There's a small nerves from here. There's we call the tympanic branch of the ninth and the auricular branch of the 10th. This is the ulnar nerve and then the Jacobson nerve. So also these nerves is very small, and then it's a little bit it's as extra information of that, right? There's an ulnar nerve is coming from the 9 and 10s, and it's going up to the mastoid areas, and the ulnar nerve is going to control the sensory of the external ear canal. Here, this ulnar nerve is control the sensory of the external ear canal. As when you see that when you drill the mastoid, you can see the small fibers around the facial nerves. This is the ulnar nerve, and then the ulnar nerves coming from the 9 and 10s, and coming up to the mastoid, and then there's a small fibers going to the external ear canal, and also these nerves anastomosis is the facial nerve. So like this, facial coming from the jugular foramen and coming up, and there's across the facial nerve is go to the mastoid, and then there's this nerve is going to the anastomosis, the facial nerve, and also there's a small branch to go to the external ear canal. And this coming up from the jugular foramen, and coming up, and the mastoid, and then anastomosis, the facial nerve, and also the external ear canal. Here, this is the origin of the ulnar nerve. So coming from the petrous ganglion, that's a ninth nerve, and then the jugular ganglion from the 10th nerve. And then these small branches coming from merge together and then go to the mastoid. And also the small branch from the jugular petrous ganglion for the ninth. This is Jacobson nerve. And the Jacobson nerve is coming from the ninth nerve to the tympanic cavity. So this is a movie of that. Yeah, you can see when you drill around the mastoid. Here you can see the small branch, small nerve is coming from the jugular, gross pharyngeal and vagal nerve, and going up and across the facial nerve, and then the small branches go to the facial nerve, and also the external ear canal, also like this. And also the tympanic branch, the Jacobson nerve is coming from the superior ganglion of the ninth nerve and the tympanic cavity. So like this. It's very small nerves, but it's very for the ENT surgeons, and this nerve is very important for the ENT surgeons. For the neurosurgeons, maybe we don't need this information, but if you want to know that's around the complex anatomy of the jugular foramen, so we should learn it about it. So it's depend on there's several pathologies that occur from the jugular foramen around here. So it's depend on the location, depend on the extension of the tumors. So we can you can select the approaches in the retrosigmoid approach and the far lateral transcondylar, or the mastoid approach, or mastoid and retrosig, and mastoid or anterolateral approach, or the combined approach like that. For there's a far lateral transcondylar fossa approach is the most useful approach for to access the jugular foramen. So usually we use hockey stick shape skin incisions like this. And then also important is we need the transcondylar approach. So it's not condylar approach, but so juxtacondylar approach is very important. So to remove this bone is very important here, these areas. So for I can show the clinical case. The tumor is the jugular foramen schwannomas. So the muscle is elevated the one piece and then push down to, and then after the craniotomy. So here this is the posterior part of the condyle. So we need to remove the condyle and then open the dura, and then after incision of the dura, so you can access to the tumors. And as you see here, there's you can use a lookup view to the jugular foramen. So here's so we have the jugular foramen schwannoma. So we have to use the very small corridor between the nerves. So we need some space. So it's the far lateral transcondylar fossa approach is very useful for the access to the jugular foramen using the looking up view. Then after removing the tumors, that's the closure. It's going to like this. And then so the tumor is not big and also cystic lesions like this, so we don't need to use the far lateral transcondylar approach, because the retrosigmoid approach is enough. So it's like look down view, but it's a tumor is not big, so we can use the retrosigmoid approach. So it's a small C-shaped incision, and then elevate the muscle, and then translocate the posterior, and then the lumbar hole was made, and then craniotomy, was done. So this is a mastoid emissary vein. So we can cut the emissary vein, and then the craniotomy was done. Oh, sorry. And then evacuate the CSF from the the cerebral medullary system, and then open the dura, and then see here, this you can see observation of the jugular foramen. So it's a tumor is like a cystic. So we can the puncture the tumors, and then after the access to the removing the before the tumor removable, so we have to identify the location of the nerves with the neural monitorings like this, and then after that, so we can start tumor removable. Then, so but as you know, so the 9, 10, 11 nerve is very fragile, so we have to keep we don't have to remove all the tumors. So we have to leave the small piece of the tumor on the nerves to preserve the nerve functions. So if the tumor is embedded inside of the jugular foramen, you can use the endoscope assist and then remove the tumors from the jugular foramen. And here's 6 nerve, and then 9, 7 and 8, and jugular foramen 10, 11, like this, and close it. So this is the last case. The biggest case is if the tumor is invaded all the way like intradural or extradural and cervical extension. So we have to use several approaches. It's a combined approach: lateral suboccipital approach, and the pre-sigmoid approach, and anterolateral approach. So the Paolo, he already showed that transmastoid approach to the jugular foramen. So first we did a mastoidectomy, and then exposing the sigmoid sinus all the way to the sigmoid sinus jugular bulb and internal jugular vein. The tumor is embedded inside of the internal jugular vein, so we can remove remove the tumor from the jugular vein after ligation of the jugular vein, and then still remove the tumors from the jugular vein. And after removing the tumor from the jugular vein, so I open the retrosigmoid dura. Then elevate the tumor, and then to identify the lower cranial nerves like this. And after knowing the location of the lower cranial nerves, again, we can incise the pre-sigmoid dura. Then after that, the sigmoid sinus can be removed with dura and sinus, and then the tumor. Then after that is a closet. So I remain some piece of the tumors around the cervical region, because the meningioma is very embedded around the nerves. So it's a cervical region is very complicated, and there are a lot of nerve anastomosis. It's very dangerous. So I don't want to damage of the nerves around the tumors around these lesions. That's only the internal jugular vein. Inside of the internal jugular vein is very safe, but the outside is very, very dangerous. So I will observe this type of tumors, and then if the tumor is grown up, and then they have the small corridor to access the tumor, so we can start the tumor removal again. But I think it's meningioma is a very not aggressive tumor, so we can remain the cervical regions around here. So as the last case is here, there's a tumor is located inside the mastoid here. This is the vagus schwannoma. So it's this kind of tumors, we don't need to open the intradural lesions. This completed the extradural lesions. So mastoidectomy was done, and then the facial nerve is here. So I preserved the facial the facial bridge with a small bone on the facial nerve. And then you can use the small corridor. So the facial recess, this is a facial recess corridor, and then also the retrofacial corridor. And then tumor is just behind the just medial of the facial nerve. So I use the endoscope assist and then remove the tumor. Unfortunately, the tumor is suckable. It's a schwannoma is a suckable tumor. Then they remove the tumors as much as possible from the microscope or endoscope assist visualization, and then remove the tumor. And then here is this is a jugular foramen lesions. So after removing the tumor, so we can check the neural monitoring, and then the nerve function is preserved. So tumor was removed. And also the very important is the carotid artery is very close to around here, so we have to preserve the carotid arteries also. So this is from the anatomy to the clinical cases for the jugular foramen. Thank you very much.
Thank you, Kentaro.